Hello, everyone. Welcome to the BMES Professional Development webinar titled Artificial Intelligence Applied to Healthcare. I'm Mehdi Rahman, and I'll be your moderator for today. I'm a systems engineer at Labyrinth Devices and located in Baltimore, Maryland, and I'm a member of the Health Tech Institute. The Health Tech Institute is a new initiative we have started at BMES to address cutting-edge topics in healthcare technology like artificial intelligence, cybersecurity, surgical robotics, to name a few. Today, we bring representatives from two leading companies that apply artificial intelligence techniques in the field of healthcare. Just before we begin, there are a few housekeeping announcements. First, this webinar is being recorded for your convenience. The slides and archived recordings will be available in the next several days through the BMES website. Next, at any time during this webinar, you may submit questions by using the online chat function to the lower left of your screen. Please submit your questions as we go. Your questions will be addressed by the speakers after their presentation. And lastly, please do not exit the webinar right at the end because there will be a brief evaluation, and we would greatly appreciate your feedback, so please take a moment to complete it. So before we begin getting into the webinar, just a few polling questions just so we get an idea of the audience members participating in the webinar today. So the first question is, which of the following best describes you? Are you an undergraduate student, a graduate student, a postdoctoral fellow, a professor, industry professional, clinician, government personnel, or other? We'll give a little bit more time. Maybe another 5 seconds. Okay, close this polling question. And it looks like we have a pretty good mix of people. We have, we have undergraduate students, quite a few people from academia, but we also have some, industry members here as well. So it's good. I think we have something for everyone in this category in this presentation today. So we'll move on to the next polling question. What is your current involvement in the field of artificial intelligence? Do you currently work in the field of artificial intelligence? Do you have a moderate sense of what it is? Maybe you don't work in the field directly, but you still have a pretty good idea of the basic concepts, the underlying basic concepts, neural networks and other machine learning concepts? Or would you consider yourself a beginner and you're more interested in learning? Maybe you've heard about it in the media, but you're not sure exactly what it is, what these terms are, but you've heard them before, and you would like to learn more. So, trying to get a sense of, I guess you could say beginner, moderate level, or, I don't want to say expert, but, higher level, I would say. Okay, give another 5 seconds. Okay. So it looks like we have a pretty good mix. A lot of people consider themselves to be beginner or moderate, but then we also have, a pretty good percentage of experts, or higher level, I would say. And again, I think today's webinar is geared towards everyone. So I think everyone can benefit from this. So we have two great speakers today in the field of artificial intelligence in healthcare, John Showalter and John Axerio-Cilies. So I'll introduce them now. John Showalter, MD, is a physician, researcher, and healthcare system leader, board certified in internal medicine and clinical informatics, with a master's degree in information systems and a proven history of building new programs and guiding them to results. Dr. Showalter currently serves as Chief Product Officer for Jvion, an AI healthcare company based in Atlanta. He is an innovative clinical and technical executive responsible for the development and execution of product and new market strategy. In his role, Dr. Showalter works with marketing, sales, data engineering, data science, and delivery teams to create and build new cognitive science products to positively impact patient outcomes. Because of his leadership, the company has expanded its product line by 200% in just 12 months. Prior to Jvion, Dr. Showalter served as Chief Health Information Officer and Chief Medical Information Officer for the University of Mississippi Medical Center. He has been recognized by cross-industry awards, including Premier 100 IT Leaders, Analytics All-Star, Clinical Visionary of the Year, and Healthcare IT Youngblood, Top Young Health IT Executive. Dr. Showalter holds a biomedical engineering degree from Columbia University, an MD from Penn State College of Medicine, and MSIS in Healthcare Management and Delivery from Penn State University, and completed his internal medicine residency and medical informatics research fellowship at Penn State Milton F. Hershey Medical Center. So it's John Showalter, and then our other speaker, John Axerio-Cilies, is a founder of Arterys and currently serves as the Chief Operating Officer. Arterys is building a medical imaging analytics platform with a focus on applying deep learning to medical images in order to improve clinical workflow. The company's SaaS medical imaging analytics platform combines the best of cloud computation and machine learning to support diagnostic and therapeutic decisions. This is the first cloud platform to deliver an FDA-cleared application, CardioDL, that leverages deep learning. John directs multiple teams, including engineering, machine learning, and regulatory and compliance teams. His technical background is in high-performance computing, uncertainty quantification, optimization, and computational fluid dynamics, CFD. He completed his PhD at Stanford University in the Flow Physics and Computational Engineering Department. So it's John Axerio-Cilies. So we have two great speakers today. And from here, I'm going to hand over the floor to John Showalter.
Thank you, Mehdi. I'm really excited to be here. I'm really excited to be presenting to the Biomedical Engineering Society. Took a deviation into the clinical side for a while and really glad to be back. I'm also really excited to be presenting with John today. My senior project in my undergrad was trying to translate the DICOM header, the wrapper that goes around images. So it's awesome to see how far we've come from, parsing a script to even just get to the images to the point where, John and his company are able to do what they do. So really excited to be here. My goal for the next 15 minutes is to convince you that AI is working in healthcare. Patients are benefiting from it. Tens of thousands, hundreds of thousands of patients are benefiting from AI right now from the work that companies like Jvion are doing, and give you some insight into the approaches that are being effective. So our goal is to give clinicians, providers, the ability to take actions that matter, know what actions matter the most, and know how best to improve outcomes for patients. So the cognitive machine is able to identify risk trajectory. So we're able to understand mathematically where the patient is headed. Are they headed towards a bad outcome like sepsis? Or are they headed towards a good outcome like wellness? Understand the factors that are driving them towards one of those directions, and also understand what can be done to modify those factors and change the patient's trajectory. We've been extremely effective. Our average annual ROI for our clients that are live with the system is $6.3 million, with a median of $3.6 million. That is all through improved patient outcomes. We don't do anything with billing or claims. It's all direct action on patients and reduction of negative events. to save that money. So the instance rate reduction, depending on what we're talking about, whether we're talking about readmissions or pressure ulcers or falls or admissions. So the reduction rate is between 10 to 15%, depending on the use case or the topic. And the resource reduction, so people are getting these outcomes by being more efficient or while being more efficient. And the workload reduction is between 25 and 75%, again, depending on what the baseline is. Every time I have this as a first talking point or slide, it's immediately how do you do that? How do you accomplish that? And the answer is we do that with an understanding of the patients in a hyperdimensional way. We are able to consider thousands and thousands of individual features and data points about the patients to truly understand what's going to happen to them next and how to stop it. So I'm going to use an example. An example I'm going to use is sepsis. So sepsis is when your body overreacts to an infection. Most people think that sepsis is when the infection becomes overwhelming to the body, and that's not really true. It's the response to the infection becomes overwhelming, and the immune system responds in a way that does damage to the body and ultimately leads to death. If you take the severest form of sepsis, the mortality rate is 50%. Even appropriately treated, it's still above 30%. So getting to it early matters. Every hour a patient is not properly treated for sepsis increases their mortality by over 7%. So if we take two dimensions of sepsis, one is the infection can be viral or bacterial, and the site could be pulmonary or GI, and just those two dimensions, we already begin to split out an understanding of the patient. We start adding dimensions like blood pressure, whether they're normotensive or hypotensive. Those two patients begin to separate out further and further in the hyperdimensional space. We start adding, age and antibiotics and whether or not there's end organ damage and where the site of that end organ damage is and what their temperature is and what their heart rate is and what their respiratory rate is and what their comorbidities were, how long they've been like that, whether or not they're getting antibiotics, and you end up with a true, complete hyperdimensional space that allows you to cluster these patients. And when you cluster these patients and, track them through time and track, hundreds of thousands of these patients through time, currently our machine contains over 13 million patients where we have their claims data, their EHR data, and their social economic data to make up those 4,000 data points. We're able to know when patients are here, what's going to happen next, where they're going to go, and we take these clusters, these understandings, and the multiple clusters that the patients sit in and get a very personalized view of the patient. Once we get a personalized view of the patient, we are able to determine the factors that are driving it for that individual level. So the current encounter can, this patient has anemia, history of surgery, fluid electrolyte imbalances, esophageal disorder, and diabetes, and those are the driving risk factors. So what do we do with that? The machine then generates personalized recommendations for the patient. Consider implementing aspiration precautions to prevent pneumonia, assess whether or not you really need the Foley catheter, the urinary catheter that the patient has, monitor their lab results more closely. So the nurse elevates the head of the bed, discontinues the Foley, draws the CBC and lactate, and is able to drive that patient's trajectory from a high risk of sepsis to a much lower risk of sepsis. We are currently have clients live on this and are able to demonstrate a 10% reduction in the incidence of sepsis. After implementing, there are 10% fewer cases of severe end organ damage using the technology. And that, drives several $1,000s of savings for every one of those that we're able to prevent. But more importantly, patients have much better outcomes when they don't, end up with their organs being injured due to an immune response. So, where have we been successful? What have we been successful with? So we've been very successful with readmissions and avoidable admissions. So stopping people from coming back to the hospital versus having people, come from the community into the hospital. So on the avoidable admission side, we've had UnityPoint Health has had a 30% reduction in their avoidable admissions. On the readmission side, greatly reduced the variation in care and have had a 18% improvement in the readmissions for chronic patients with chronic conditions. Another example, stay out of my time. Sepsis health, so health regression. So looking over, the next 3 to 12 months, who's going to get sicker, who's at the greatest risk, who needs additional resources and care management. This is being applied to an employee-sponsored health plan that has about 5,000 employees. We've had a $5 million, about a $5 million reduction in paid claims and a total overall reduction year over year about $3.2 million. So on a 5,000 patients or 5,000 employee and family health plan, we're able to reduce the cost of that health plan by over $3 million in the first year. And then finally, pressure injuries and sepsis. Again, with the sepsis example, we've been able to, reduce sepsis by more than 10%. In this case, we're looking at almost 25% reduction in sepsis cases, so the severe end organ damage part of it. And on pressure injuries, reduced pressure injuries by 17%, which translates to several $1 million cost avoidance per year. And it's all based upon a hyperdimensional understanding of patients and then, machine learning approaches to determine the risk and the correct actions for those patients. So with that, I think I'm at my 15 minutes, and I'm going to turn it over to John, because maybe we're taking questions at the end, right?
Right. So thank you, Dr. Showalter, for that presentation. And now I'll give the floor to Dr. Axerio-Cilies.
Great. Thanks, everyone. It's great to be here. I'm just going to share my screen and make sure that you all can see that. Maliki, can you still see my screen?
Yes.
Okay, fantastic. So yeah, just quickly, just a high-level overview of Arterys. Our vision really is to achieve the full potential of medical imaging, and that's through augmented intelligence for really confident diagnostic decisions anywhere in the world where care is needed. And we think innovation matters, and we're focusing on that. And basically, through our partners, we want to create a revolution in medical imaging through this cloud-based AI diagnostic solution. Just on myself, I'm actually a mechanical engineer by background, so biomedical engineering is near and dear to my heart. I really love to hire engineers, really anywhere within the organization, because I think that they just know how to solve problems, and I think I can't emphasize that enough. And specifically in what we call product management, which is this idea to really define exactly what the products are doing. I again love hiring engineers that have a biomedical background, because they understand both sides of that, which is sometimes challenging. So I actually met my co-founder Fabian because he had sleep apnea, and I was doing some work in computational fluid dynamics, and he had come to me saying, hey, can you stimulate your upper airway? I said, well, let's give it a shot. And that's kind of how Arterys got started. It's been a great ride. It's been over 5 years of development. We're actually regulated. We're a software as a medical device, and we're regulated in 95 countries. We have 5 FDA clearances, and we've been steadily growing. And we feel strongly that AI can really make a difference in the clinical workflow for specifically radiologists, but really anybody interacting with images. Just at a high level, what we've been able to achieve so far, we've been able to commercialize a technology called 4D Flow, which allows an MRI to capture blood flow information using a free-breathing MRI sequence. And so it's not CFD, unfortunately, but there's actually some interesting research being done to compare the two. We've been doing a lot around deep learning and leveraging the cloud and a full AI platform to be able to do that. Patient privacy has really been a hurdle, and we've been able to solve that through software solutions. And of course, the FDA is another hurdle and really a long pole. And it's not only the FDA; there's other agencies across the world that need to ensure that our devices are safe and effective, because we are what's called a Class 2 medical device, which supports in a diagnosis versus actually providing a diagnosis. So we're not replacing a radiologist; we're augmenting them. Some of the challenges in medical imaging are really around this idea that a lot of the departments are siloed. There's not a lot of great communication between different people. There's a lot of data, so there's and it's only growing. So medical imaging, 20, 30 years ago used to be maybe a single chest X-ray that you'd put up on a wall, and today, we're generating gigabytes of data for 3D data sets, and it's really only growing. And a radiologist cannot view every single image, so we're getting burnout from radiologists. We're seeing that there's a lot of inter-reader variability. The quality is just not there, and so we feel AI can really help in democratizing care, increasing the level of accuracy of the average physician, and again, being able ultimately to help improve patients' care path. AI in medical imaging has grown substantially. I think this graph is from 2016, and the number of publications is really growing exponentially. There's so many startups in the space, and when we look at the entire landscape, medical imaging, let's say the landscape for AI in healthcare, medical imaging is a huge portion of that because the data exists. And I can't emphasize enough how important data is to everything we do on a day-to-day basis, and it's structured data, very, very different from a lot of the other types of data that exist in healthcare that is really unstructured and not really sitting on databases today. And that's kind of been one of our reasons why we've been successful. A lot of the data already exists, and it's a matter of extracting it from hospitals. I wanted to emphasize that creating an AI solution is really, I would say probably 3% in modeling, and the rest of it is in the non-modeling piece. So if you're an engineer thinking that you'll go into industry and trade models all day, that is just not the case. And what we're seeing is a lot of the time that our engineers are spending is really on the software development side and primarily data wrangling. And again, I can't emphasize that enough, is this idea that the data just doesn't exist in a clean, data warehouse that you can just pull and start creating a model. Part of the problem is realizing what we need to extract from that data. What are we trying to exactly measure? And that's more the product management side, like really defining acceptance criteria for the algorithm to say, hey, what is good enough? So for example, if we're trying to detect lung nodules, is 75% accuracy good enough? Like, what's the current accuracy? These are all questions that we constantly are asking ourselves, because not having an algorithm to say that's 96% accurate really means nothing if you don't know what the baseline is. And it's not just in data wrangling, it's everything else I mentioned around regulatory, being able to distribute having a sales and marketing department So really the commercialization is the most challenging piece. And really, like I said, if I gave you structured data or my engineer structured data, you could create a model overnight probably using a lot of the great tools that are out there, and TensorFlow and others. But again, that's really just a small fraction of the challenge. There is a revolution happening in the digitization of all the data that's in a hospital today, and currently the infrastructure is really it's separated by functionality. So you have these universal viewers that can view images across departments. You have very advanced software to be able to quantify specific clinical workflows, like for example, lung nodules or liver cancer, or trying to measure the function of the heart. So these are very dedicated pieces of software. And you have what's called PACS, which is called Picture Archiving and Communication, which is really a storage and viewing solution for the day-to-day radiologist. And our goal is to really transition all of these legacy on-premises systems to a 100% web-based medical imaging platform. And that's how we can use AI and constantly learn from all the data that we're collecting to help improve the clinical workflow. And we feel like deep learning is really part of the reason why we've been able to make an impact, because it's allowed our engineers to really develop models very quickly. And we've seen already, we've been in production since the beginning of last year, we've seen between 30 and 70% productivity increase depending on the organization, just from having the AI deployed. And what I'd love to do is spend the last kind of 5 minutes actually showing you a real demo of our system, because again, a picture's worth 1,000 words. What I'll mention is that we use deep learning for a lot of things, and from detection of pathology to segmentation, so outlining the border of certain pathology, triage, which means saying something as abnormal or normal, classification, tracking, prediction. So there's a lot where deep learning can actually help. So we've been able to combine kind of the cloud, the deep learning, and the web to be able to offer this platform. And we currently have 3 products: cardiac, lung, and liver, and expanding. So what I'll do is I'll spend the next few minutes showing you our actual system. So here I'm logged in. It's just a standard Chrome web browser. And what I'll do is I will load a specific case. And when I load it, what happens is so our servers are actually all across the world. We're on our backbone is Amazon Web Services, but we also use Google Compute Cloud for machine learning purposes. And when I'm interacting, I'm based in San Francisco today, and our servers are actually all over the world, but I'm actually connected to Virginia. So what happens here? If I try to let's say go to a one-up view, and what I'm going to do is render an image here. Let's say I try to render the specific series. So in a conventional cardiac MRI, there's a lot of series. So there's a lot of little scans that are being acquired. So in a standard viewer, you can view this data. So that's what I'm doing here. You can zoom and pan and again, be able to just basic viewing. I can also bring in more complicated workflows. So for example, this is 4D flow. And here what I can do is I can interact with this 3-dimensional data set in real time. So if I go to this panel, what you're seeing on the right there is the performance of the network. So I can get 23 to 30 frames per second just in a browser environment. So which is really unique, and that kind of allows us to unleash the power of the cloud. So I can also animate this. So here what I'm doing is showing the full cycle of the heart over time, and color is represented is speed of the blood. Red is high speed, blue is low speed, and it allows clinicians to be able to diagnose what's happening with these patients. And it's not only visual but also quantitative. So we use machine learning to automate a lot of the workflow around, for example, detection of identifying specific valves in the heart, identifying flow quantification. So what I can do is I can go into flow and, for example, click in the ascending aorta, and I can see here that there's 3.4 liters per minute flowing through the ascending aorta. And we use machine learning again to automate as much of the clicks as possible and automate these quantifications. And it's not just in cardiac, we also have it for oncology. So what I can do is click on a chest CT scan here. And what happens is we've automatically detected any nodules in the scan. And here I can cycle through the nodules and cycle, the visibility just to give you a sense of what these nodules look like. And it's actually a challenging problem because if I zoom out here, let me just maximize this view and zoom out a bit. What you'll see is radiologists typically spend 1 to 2 minutes looking at this exam. And if you're trying to find a little dot in this image and you're not experienced, it's actually very hard. Now, experienced radiologists are so trained at this, and they'll know that, oh, right there is one, but I actually don't even know that's one. For me, I'm a novice, and I have to look in 3D, and in 3D it actually looks like a vein, or an artery. So it's actually a hard problem, and again, AI is so helpful for really the inexperienced or the mediocre radiologist to just cycle through these nodules to really quantify the size and score it. What's also important is be able to track these over time. So what I can do is I can bring in a case that was 1 year later. And if I do that, our system, what it does is it co-registers these two series together. And co-registers means kind of syncs them up. And then also we're able to track over time these nodules to see if they've grown or not. And again, we do that automatically. So for this scan, what I'll do is I'll scroll through the stack here so we've synchronized that. And so for nodule 1, I can kind of cycle through these two exams. Even though on the left and right they're about a year apart, we can show the changes in diameter or volume, which is important for follow-up reasons and to make sure that the treatment is actually, whether the actual nodule is growing or not, or whether the treatment is successful. And again, I can cycle through these nodules. And we have kind of the same workflow for other types of cancer as well. So in this case, I can load a liver exam, and this is in this case MRI. And again, we use machine learning for detection of these nodules and for segmentation, for quantifying the volume of these lesions. And in this case, same thing. It's auto-detected these lesions, and I can cycle through. And in this case, we've characterized them as well. So, and characterization means, in this case, whether it's a probable HCC, liver cancer or not, and we have kind of workflows for reporting. So ultimately, the radiologist is creating reports. And so one thing I'll kind of stop there, but one thing I want to emphasize is that AI for us is not just in saying something is abnormal or normal. We're leveraging it across the entire workflow to automate any sort of click. And it doesn't have to be related to an image. It could be related to automating which series to look at next, or what window levels or what brightness contrast to use. And since we are cloud-based, we're constantly measuring what our users are doing, and we try to optimize in order to reduce the time and increase accuracy. So with that, I'll stop there, and you can take any questions.
Great. Thank you, Dr. Axerio-Cilies. So from here, we would like to take time to get to your questions. You may continue to submit your questions using the online chat feature on your screen, and we will get to as many as we can. We actually received a few questions in advance of the webinar, and we'll just start with those first. Okay, first question. What advances in technology, for example, software, user-friendliness, do you think are necessary to advance the role of AI in healthcare? So if either question. Maybe I'll go to Dr. Okay, go ahead.
I'll dovetail to some of what John said. Data access, it's data harmonization, interoperability, APIs, even just better cloud-based underpinning of the clinical systems. There are a number of clinical systems that don't have really good or timely updated offline copies to use. So you have to go against production systems to get real-time data to truly be able to influence clinical decision-making in real time. So I'd say that on the top of my list of things that have to get friendlier are the structures and programs and software that gives us access to data.
Yeah, and I'll add to that. I would agree. For us, integrations is probably our biggest bottleneck. And what I mean by integrations is being able to connect all these systems together via standard APIs that don't exist today. And it's again, our users need to be able to access all this information in one place, have one UI, one simple way to do it. And today, unfortunately, we're nowhere near that.
Great, thank you. Next question. How will AI change the channels of healthcare and the diagnosis and treatment of diseases? AI has proven to be more effective in evaluating diagnostic tests and accurately providing diagnostics. How will the channel continue to change? If there are differences in diagnoses from a physician and AI, how are they resolved? Curious to open the discussion.
I can start, and John maybe can add. I think there's been a lot of companies that have made certain claims around accuracy and around impact. I think we've approached it more from the perspective of augmenting the physician as opposed to replacing them, because the most important piece is AI will fail, and focusing on these failure mechanisms, focusing on these edge cases. How are we going to report that back? And so the way we've been able to think about solving that is through a UI, or through a way that a user can accept or reject. Because the stakes are a little too high to just to triage, say, hey, this person has cancer or doesn't, and no human will ever look at that. We're not there. We're not quite there yet from a technology perspective to be able to do that. And I think it'll take a few years. And some people say 3, some people say 40. I would say we're still at least 10 years away from having a system that is really autonomous. So that's why the way we've adopted AI is really from automating a lot of the tedious tasks.
Yeah, I mean, we've known since the 70s that if you give a computer all of the details about a patient, they diagnose more consistently than physicians. The inter-reader reliability, the inter-rater reliability is much higher with the computer-based systems than with physicians. However, they're still not perfect, and they're very far from perfect, and there are very few algorithms or approaches out there that get you a high enough sensitivity, specificity, positive predictive value, negative predictive value that you want to remove the physician or the human from the process. And there is so much unknown about healthcare. There's still so much we don't understand about diseases and physiology that the humans need to be augmented to advance where we are today. So I think augmentation is the right approach, as opposed to trying to be replaced. And when we can get to a level of exactness, we should replace it. I mean, 60, 70 years ago, physicians put blood smears onto slides and went with clickers and counted to figure out, what the hemoglobin hematocrit levels were and manually calculated those. And those are all done by machines now. And there was a lot of discussion then about, should machines be doing that or should we have people do it? Well, machines did it much more consistently and, accurately, ultimately. Not the early ones, but the ones that we have now do it much more accurately, and the physicians can move their diagnosis to not taking the time to count red blood cells, but know how many there are and see how that affects the patient. So that kind of augmentation is, to me, a much better trajectory than concept of replacement.
Great. Thank you for that. Next question. How relevant is hardware research in this decade where the significant focus is on machine learning and virtual reality advances in the healthcare field?
So I sat on an advisory board for one of the major hardware companies, and hardware research is going to be critical because right now, John and I are talking about interoperability. It's a huge thing. I don't think either one of us are going to be happy where the interoperability is in a decade, but it's going to be much more advanced than where it is now. And with the amount of information that we are producing, understanding how to best store, compress, access, analyze, in-memory, solid state, hybrid, models, totally going to be needed to keep up with what we want to do with AI in the next, 10, 15 years. If they stop developing the hardware today, we'd probably outstrip it and be very unsatisfied with it in the next 5 years.
Yeah, I would second that. I think we are just scratching the surface of what some of these imaging modalities can do. Like, for example, MRI. 10 years ago, these things were creating images, with resolutions of millimeters, and now we can get, a tenth of that in the micrometers even. So again, like, that's so important. So we're just as good as the data, and we're, like I said, we're scratching the surface. So I think it's we have to work in harmony between software and hardware.
Okay, great. Thanks for that. Next question. What programs, technology, and products are most important for an uprising biomedical engineering student to learn to get ahead in their field?
I may be biased, but having understanding of software, I think it will be helpful. But again, depends what you're doing. If you're creating a needle, then no. But if it's something related to AI, I think having some kind of background in architecture or software or basic understanding of programming, I think can really help. And the more stronger your development skills are, so I think the stronger engineer you will become, especially in AI.
Yeah, I was going to say the most important thing is figure out what your resources are going to be. Where are you going to go to keep up? Because I can tell you, back when we thought we were all kinds of really cool because we broke a DICOM header, and that was 17 years ago. So in the last 17 years, we went from cutting-edge research being programming how to get through the wrapper so that someone could look at an image to the work that John is doing. I can't tell you what the technology is going to be in 2035. I can tell you that if you don't have a plan and know where your resources are and a plan to keep up on your resources to stay up with the field, you will get left behind.
Okay, great. Thanks for those answers. Next question is actually directed to Dr. Showalter. Based on my investigation of 100 stakeholders, the consensus was that physicians that suspect sepsis do not wait for labs before initiating antibiotics.
So I'm assuming that you asked physicians, so I'm going to say this as a physician. We think we are fabulous at treating sepsis. We're all over it, and our egos can't handle the misses. So I've actually done a lot of research in sepsis, and I've published in sepsis, and bringing even just education and recognition into identifying when to treat sepsis and when we really need to tackle it can reduce mortality by 35%. We have a cognitive bias that we're really tackling it, and we are looking at septic shock. There's just an article that came out from the Cleveland Clinic. The accepted cutoff for when you need to worry about the patient's mortality increasing is a mean arterial pressure of less than 65. The Cleveland Clinic just showed that for every hour it's under 85, the chance of mortality goes up 3%, and the risk of end organ damage goes up 7%. So, we aren't managing blood pressure the way that we need to be managing blood pressure in sepsis. We kind of feel like I order antibiotics, I'm good to go. And we don't actually give antibiotics correctly or empirically well enough to really tailor it. So, and additionally, within the last year, with the work that we've been doing at Jvion, end organ damage and sepsis is a preventable event. So prevention is actually a thing that should be on the physician's mind, not just early antibiotic treatment. But I completely believe your assessment as a hospitalist, as a physician leader at a medical center with more than 2,000 docs and PAs and NPs. That is absolutely their mindset and their consensus. It's just not backed up by the empiric research.
Great, thank you for that. Next question is, are there specific machine learning algorithms which have been seen quite often in the fields you work in?
So I'm going to let John take the imaging. I'll take the prediction diagnosis. So decision trees, random forest, XGBoost, working extremely well, are kind of the base standard. They're actually in the process. It's not really accepted yet, but they're in the process of revolutionizing what we think is predictable, especially how easy they are to implement at this point and how little compute they use compared to the compute we have. So the ability to do XGBoost or random forest really coming into the clinical prediction side of things. You should know those inside and out. Back to the last question, if you're talking about things you need to know today, be really versed in XGBoost. I'm sure John's going to bring up neural networks, but I'll let him talk about that. And then, a real understanding of how hyperdimensional spaces work is the current foundation for the cutting edge.
Yeah, thanks for that. I would agree. Everything we do is imaging based, and unfortunately, after ImageNet, like a lot of the algorithms that were created for that, translate very nicely to medical imaging, although they do need to be tweaked. So we use convolutional neural networks for almost everything we do, and we try to keep up with the technology and the research that's been out there just for live images. And what we've just recently started using GAN, so general adversarial networks as well, that to kind of help us improve our models and accuracy. So that's what we use.
Great, thank you. This question is for John Axerio-Cilies. Regarding the model used by Arterys, how does the model adjust to previously identified abnormalities in the medical image?
So I guess maybe the question was around how do we generate our ground truth, or was it more around, because our pipeline, the way it works is we collect raw images from hospitals. We then annotate those images from experts, and that creates the ground truth data. We then create our models, and we deploy those models to our production environment. And so we take in changes from our UI, and that kind of gets fed back into the ground truth data, and we retrain to improve our models. So that's kind of the generic pipeline. And when we do have cases that we haven't seen before, the machine learning will fail. But hopefully, with enough of those cases and generating enough data, then we can retrain and redeploy. So I'm not sure if that answered the question, but hopefully it did.
Okay, great. And somewhat related to something you just said, again, a question to both of you. Compared to the ability of very experienced clinicians, how well does AI do with disease diagnosis? And does AI do better or worse at detecting extremes, that is, rare cases?
Yeah, so what I'll say is our claim is that we are as accurate as an expert physician. And we define that based on consensus of between 5 to 10 experts in the field. And so we will never be better than them. That being said, if you compare our algorithm against a mediocre or a beginner radiologist, yes, we'll probably outperform them. So that's on my side.
Yeah, I mean, there's there are very few things as accurate as a physician that has seen a lot of something. But generally, physicians don't see a lot of something rare. They see one or two. And, depending on the condition, there's a really long lag. Rare conditions typically have something like a 5 to 7 year lag between presentations of symptoms and accurate diagnosis, assuming that the diagnosis we've currently given them is accurate. So it might even be longer. In rare conditions, AI is extremely helpful in appropriately bringing that up to a clinician for consideration, especially if it's paired with, and this is the action you should take to consider it, this test, this physical exam, looking for this sign, this symptom. We have an awful lot in ours of, checking for signs and symptoms because it's not always done. So it's very good for augmenting the decision making. The accuracy, again, as John was saying, you can't really measure the accuracy against any one physician. You need to measure it against a panel of physicians. Is this something that every physician was going to miss? Is this something that 3 of 5 physicians were going to miss? Is this something that every physician was going to know? So it's a little different when trying to compare AI performance, which is a lot more consistent. You push the data through, you're going to get the same answer every time. You push that same data through 5 physicians, and you end up with scenarios where they all agree, scenarios where they all get it wrong, and scenarios where it's a mixed bag. And AI does a really good job benefiting when they either disagree or they all got it wrong. And there are rare conditions where it is just so rare it would never be in their mind, and 49 out of 50 would get it wrong.
Okay, great. Thank you for that. Next set of questions. Do you think AI will be important in tissue engineering and organ replacement? And how do you think AI can be used in surgical robotics?
So AI is already being used really effectively with the Da Vinci motion setching AI that's currently in place. So one of the biggest problems with minimally invasive surgery with the Da Vinci robot is when you have to rotate the patient. And when you rotate the patient, you then have to go back and reset all of the instruments. And that's one of the most dangerous parts of the procedure, and where things get nicked that weren't supposed to get cut. And they're now using AI to help keep all of that in alignment with the AI based upon the cameras and accelerometers and other information, so that as you rotate the patient, the instruments stay in the same place in the body. It's made things much safer and much more effective. So that ability to sync with images that physicians are looking at, or maintain positions inside the body while patients have to be returned. It's amazing how many surgeries actually require the patient to be repositioned in the middle of it, and then everything has to start over again. What was the part before the surgery AI again, Mehdi?
Tissue engineering and organ replacement.
Yes. So so I do have a minor in tissue engineering, and the AI we're not going to optimize the artificial tissue structures without some AI help to understand that, and we're not going to be able to accurately model the correct fluid dynamics or microbiology activities in those tissues without AI assistance.
Okay, great. John Axerio-Cilies, do you want to chime in on that, or?
Nope, that was great.
Okay, great. Another quick question: which programming languages are utilized most often in your experience?
I can answer quickly. Our stack is front end is just HTML, CSS, JavaScript. Our middle is primarily JavaScript, and back end is OpenCL, C++, those sorts of things. On the machine learning side, it's primarily Python for running carrots and then TensorFlow.
Okay. Python and R.
Go ahead.
Python and R. So and Python is, I think, underrepresented. R gets all underrepresented. R gets all the hype. Python's actually can be really, really effective in AI, and is an asset, especially to the students out there. Knowing Python gives you a lot of flexibility, especially as John was talking about in the software development space, and getting your AI to sync up with your software. R doesn't do that at all. You can do that with Python.
Okay, great. So I'll just do one last question before I wrap up here. So for each of you, guys kind of already mentioned this. What resources do you guys recommend to keep up with the time?
I would say just stick to some blogs. Like there are some great blogs that kind of summarize all the publications in the space. I subscribe to Hacker News. There's other great news sources to kind of get a sense of what's happening in the space.
Yeah, so I couldn't agree with John more. I would not, and the academics here might really make faces at me, but I would not go to the primary literature as my screening area. There will definitely be primary literature that you want to read that matter, but take it up a level. Find an industry blog at the highest 10,000-foot level, something like His Talk. That's a blog that aggregates all of the health IT activities and events to know what other companies are doing is good. But a lot of the universities are publishing lectures and classes. There's a couple great ones out there in neural networks and advanced neural networks that can really help you get started. But I would find some place to do the screening so that you're not reading a bunch of things that don't relate to what you want to do, and then dive deep when you need to.
Yeah, there's so much fluff in a lot of these publications that it's not worth your time to read.
Okay, great. So thank you for your question. That is all the time we have for today. For those questions we did not get to, we'll pass them on to the speakers to follow up with you. And also, before you go, you can access previous webinars and see information on future webinars if you go to our e-learning link, which is up here, bmes.org/e-learning. And so you can go to that link and see what webinars have been in the past, and go to it to keep an eye on future webinars that we'll have on these topics. And additionally, our annual meeting is coming up. Our 50th anniversary annual meeting is coming up in October in Atlanta, Georgia. And we have programs for everyone, whether you're an undergraduate student, graduate student, whether you're in academia, or last few years we started to introduce industry panels as well. And so if you're interested in that, we have resources there. So please check out the website. And then coming up in 2019, we also have another conference, BMES FDA Frontiers in Medical Devices, which will be in the DC area. So just keep an eye on these things. So with this concludes our webinar. Thank you for joining us. Please stay online and take a few minutes to complete the brief webinar evaluation before you go, because we would really appreciate your feedback. We would also like to remind you that the webinar is being recorded for your convenience. The slides and archived audio recording will be available on the BMES website. You'll be notified by email when the archived materials have been posted. We hope you will join us again for other BMES events. And please take a look at these links if you want to learn more information. Thank you very much. Have a great rest of the day.